My name's Justin Lee. I'm a consultant radiologist at Fortius and Chelsea and Westminster. I've got a special interest in sports imaging. So yeah, I'm one of the Olympic radiologists, work with lots of Premier League, football and rugby. Thanks for coming, amazing turnout tonight. So yeah, brilliant, well done. Right, so first of all, my bit, unsurprisingly, is to talk about imaging, and I'm going to talk about lower limb overuse injury, because I don't know how many people here could consider themselves runners. Okay, so you know, every runner gets injured. I mean, someone said to me, you know, anybody who walks up to the start line of a marathon who's not injured hasn't trained properly. What I'm going to talk about is about some of the reasons why we get running-related injuries, and we'll talk about the etiology. I'm going to talk about the epidemiology of the lower limb muscle, lower limb overuse injury, and then I'm going to talk obviously about the imaging, okay, and how as physios or as sports physicians you might choose which imaging modality you're going to go for. So how many times do we see these injuries? Well, unsurprisingly in running, it's probably high in this bit, and if you take all sports together, 75% of athletic injuries can be defined as overuse injuries. Now obviously that will change from sport to sport, but if you take all athletic groups together, this is the numbers that you come out with. As we get older, we do tend to move away from team sports and go into individual sports, so and inevitably they become endurance sports, because actually if you look at endurance sports, the difference between a young man and an old man is not quite as wide as it might be for a more explosive sport. There are intrinsic and extrinsic factors. The intrinsic factors really refer to the anatomy or your muscle imbalance, which you guys will know a lot more about than me. Faulty technique, incorrect equipment and incorrect training program all apply to me and probably most of your patients who come with running related injuries. But essentially it's the same, whatever the outcome, whether it be a muscle, bone or a joint or a tendon problem, it's always the same. It's repetitive microtrauma and not giving yourself enough time to recover, and then you go further with trauma. So how do they present? Well, it's a very wide variation, but if you group them together and say, well, how does it present an overuse injury? Well, you can talk about a defined performance limitation. That is, you know, that is definitely true. You see that in your patients, you see it in yourself. You're not performing to the, you know, your maximum capability. And there can be a small, subtle effect. And one of them, this last thing, lack of confidence in the affected limb. Again, I think you'll see your patients and again, if you're athletic yourself, this idea that you don't want to push the limb because you're worried about it. And then again, that has an impact on your performance. Now, this isn't a hard and fast classification. This is just how I do it, if I'm assessing some imaging of an athlete who's got an injury, I might decide to look at it in this way, which is that I'll look at the bone structures, I'll look at the joints, the structures around the joints, and the tendons and the muscles. So I'm going to talk about bony injury because really this would make up a very large proportion of running-related overuse injuries. And has various names, shin splints, but really it all refers to bone stress, and it varies from a stress response to the end result being a stress fracture. So up to 10% of sports medicine practice and imaging is a bony overuse injury. But essentially, just to get it out of the way, it's a medial or posterior pain on exercise, and principally starts as a periostitis. It can be very tender, but the patients will report it after a certain period of time running. It's a classic presentation. So what else could be causing it? Well, there are some of the soft tissues around the border of the tibia, which also get inflamed, and we do see that in extreme cases, that you get a very marked inflammation around tibialis posterior. Now, the traditional way of diagnosing this was to do a bone scan, but essentially, if you look at shin splints, you get this linear, what they call increased uptake, and it is very sensitive, and it's as sensitive as an MRI for making the diagnosis. It's just you lose all the other information about the soft tissues, and this is the MRI equivalent, which is where you get a focal area of inflammation at the back of the tibia. Now, this being, some people might refer to this as a cilial tug syndrome, because you can see that that's the origin of the cilius muscle. It has three origins, actually, or three terms. It has a tibial origin, a fibular origin, then it has a central non-bony origin. And that some people might call a posterior shin splints, others might call it a cilial tug syndrome, but essentially it's a repetitive overuse. So stress fracture, I mean, the difference between a stress fracture and a stress response clinically, again, I think can be difficult. But pain at rest is a worrying sign. And if they start to exhibit some swelling, redness and warmth, that would be a very worrying sign, particularly in the foot. So some people talk about the sport-specific nature of stress injuries and other injuries, but I find that it's not quite as simple as that, and there's a lot of crossover between the various stress fracture sites. Medial posterior rib stress fracture is probably the most sport-specific stress injury, but in the runners, fibula, tibia, pelvis, but really it's metatarsal and navicular as well. Now, MRI is most of the time easy to make a diagnosis of a stress fracture. Now, just to get some of the sort of sequences out of the way, people worry a little bit when they're learning about MRI about sequences, but this is a T1 weighted image, and this is an anatomical sequence, and this is what we call the pathological sequence, because this is all of the fat, whether it be subcutaneous or marrow, is suppressed. So if you have inflammation, which predominantly is water in the body, it shows up as white. So any water is white. So if you have water in the bone, that's abnormal, and that's known as bone marrow edema. The difference is that sometimes that line that's running through there, which is a typical position for a proximal tibial plateau fracture, stress fracture, you might not see that on the pathological sequence because there's so much edema in the bone. So you nearly always have to have a second non-suppressed sequence to find the fracture line, and that's a typical proximal tibial stress fracture. This again is the distal location for a stress fracture in the tibia with some periosteal thickening, and this is the problem, or one of the problems with relying on x-rays. Now this x-ray actually shows it quite nicely, but that's about as good as you're ever going to get for a stress fracture of the distal tibia, a faint white line. And up to half of radiographs in the presence of a stress fracture are actually normal, and that includes the metatarsal. So, you know, if I look at this x-ray here, you might say, well, what's that? Well, possibly, but you wouldn't really put your mortgage on it. Maybe that one, yeah, okay, fair enough. And then you do the MRI, and it's absolutely barn door, okay? So again, the anatomical sequence, pathological sequence, and another pathological sequence. So that's distal tibia, that's common in runners. Now, this doesn't show too well, but the os calcis is obviously a common site for a stress fracture. Now, this is the typical location of a calcaneal stress fracture. So they parallel, doesn't really show too well, but they parallel the posterior cortex, and they're coronally orientated on imaging. And again, the plain film can or is normal. And even on a CT, it's pretty hard to make it out. But stress fractures on CT really looking, they have two forms, which is, I never quite get my head around, but if you have a stress fracture of the pars interarticularis, which is an extremely common place to have a stress fracture, they look like a fracture. In other words, you get loss of bone and then the bone separates. But in certain places that doesn't happen, and this is one of them, that actually you get the opposite, you get collapse of the bone. I'm sure it's to do with the different tractional forces that are going on through the bone, but still it's interesting because what can happen is people can look at that and go, well, that's healing. So it's a healing stress fracture. And the problem with saying that is that actually that's not correct. What's happening is the bone has lost its integrity and it's crunched down, so you've got denser bone than you should have. So CT it can be slightly misleading in that situation. So I'm talking about navicular stress fracture specifically now, because this is a common fracture that we see, and it's a common problem, I think, for the surgeons. We do see it in sprinters. We see it a lot in ballet, and we do see it a lot in football. And it's quite a classic sort of pattern, because what tends to happen is that you get this sort of inverted Y configuration. So the fracture, as the stem is at the top, and then it comes down in inverted Y, and I'll show you that again in a minute. But there it is on CT, and I'll show you another picture of CT in a second, but there it is on CT with the stem at the top of the navicular. These are the MRI images. Again, it can be quite hard to make out the fracture lines, to be totally honest, on MRI. But again, if you see a completely edematous bone, then that's always going to be abnormal. And this is the fracture line just running here. So this is the navicular, starting at the top, and we're running down, and that's a split in the navicular. Here it is now in coronal, and that's a pretty inflamed, bad stress fracture of the navicular. Now here it is in CT just running through. That one, this is the same case each time, but there's the inverted Y that I was talking about. And it's also with the blood supply, because there's a paucity of the blood supply right in the central aspect of the navicular, and that's the bit that, unsurprisingly, gets the fracture. Now, management, I'm not a surgeon, but I'm aware that the management is not quite as clear-cut as you might imagine. The non-union rate is quite high. Often underdiagnosed, a third of all athletic stress fractures, and this is very common to get this delay between fracture and diagnosis, and 4 months to heal post-treatment. Now, metatarsal stress fractures, very common, full stop. In the athletic group, we will see it in runners, ballet dancers, and gymnasts particularly. And in football and basketball, it tends to be the fifth, but the others tend to be the midfoot, second, third, and fourth. So just moving away from the bone now and looking at the tendo-osseous injury, because this is a more specific, a lower proportion of the injuries that we see. But I just want to talk about it because I think it's interesting. And it's to do really with an accessory bone in the tibialis posterior insertion. And there are 3 types, supposedly. Type 1 is quite interesting because I describe that as the sort of mini kneecap inside the tendon. Type 2 is where you actually have a separate bone that's lodged onto the medial aspect of the navicular, and type 3 is when you get this hooked round navicular process. But basically they present the same, medial foot pain, most common with the type 2, and they get stress across that synchondrosis. And in runners it's a real problem because it's usually associated with abnormal biomechanics anyway. And this would be a type 2, so basically it's not a small little pebble, it's a big lump of bone on the inside of the midfoot. This is the talus navicular, and this is the accessory bone here. And this is a typical appearance now. So this is our pathological sequence. This is the accessory bone, that's the normal navicular, and that's the synchondrosis, and that's lots of bone marrow edema on either side. So this is the osteotrigonum with probably a little bit of the posterior talofibular ligament attached to it. Typical MRI, lots of marrow edema at the back of the talus, lots of marrow edema in the ossicle itself. And again, another appearance now where you've got lots of inflammation in the back of the bone, lots of posterior capsulitis, and this is the so-called nutcracker. So you put them into plantar flexion, and the space between the 2 areas gets smaller, and the small osteotrigonum gets nutcracked. So again, you can see small little variations in this, which is a sort of incomplete osteotrigonum or a stress fracture through the tubercle. We try and inject them, and often I am injecting these guys either at the beginning or the middle of the season to get them ready for surgery at the end of the season, because they don't want it, once they go to surgery, then that's their season done. So this is not a curative procedure, but it might hopefully just hold them long enough to get them through the season, and it often does, but you can't keep on injecting them. It's not reasonable. So I'm going to talk a bit about now iliotibial band. Key thing really is about the anatomy. So you've got the skin, iliotibial band, and then lateral femoral condyle. It's often limited posteriorly when you see the inflammation by the lateral collateral ligament. And in terms of imaging, we have to be a little bit careful because this is the suprapatellar pouch. This patient's got an effusion, but sometimes that fluid goes all the way back there, and if you're not careful, you're calling iliotibial band in somebody who's actually just got a joint effusion. So, as I said, often limited posteriorly by the LCL, and it's a classic presentation. Now, what is not so common is the development of a bursa. Now, this is about as bad a bursitis as you will see. You do occasionally see this. Probably, I don't know, 1 or 2% of iliotibial band, you get that much fluid between the two, more often than not. So this is, again, a massively impressive iliotibial band bursa. But you've got to be careful because he has an effusion, and before you know it, you're calling an ITB bursa in somebody that actually just has an effusion. But this is, slightly different, and you can see again limited posteriorly by the lateral collateral ligament, biceps femoris tendon coming down. This is much more common, and again, even this is quite a severe case because most of the time, now this is the iliotibial band, this black line coming down onto Gerdy's tubercle. The inflammation is there. The severe cases, they get it up there. But the really severe cases get it on the superficial surface. I mean, that's unusual. But this guy, he's not got much body fat. So, he's obviously really gone for it on his marathon training. But, to get the inflammation superficial, you're really talking about somebody who's really gone for it. So Achilles tendinopathy, this is a nightmare diagnosis. It's classically the mid-portion swelling and pain. We can make the diagnosis typically on ultrasound. You don't really need an MRI for Achilles tendinopathy. It may be that it's just clinical because you know when a patient has Achilles tendinopathy. What you won't know is whether they've got a tear in there. And that's maybe why you might send them for imaging. You might also send them for imaging to look at the degree of vascularization, because vascularization is associated with poor prognosis or worsened pain. Now, how do you treat it? This is one of the options. Put your feet up and drink tea, watch TV for a couple of years. I don't think that really works. I saw that we had this, the British Society of Skeletal Radiologists, somebody put a post on saying, how do you treat your Achilles tendinopathy when a patient gets sent to you? And that was like the most popular comment. But I mean, I wouldn't think it's as depressing as that. Now, you guys will tell me a lot more about how you manage it. And I know there's controversies about eccentric loading and your other methods, so I obviously am not going to go there. But you will see patients who come to us for an injection. And I almost never do it unless they've seen one of you. So which one do you use? Well, there is a range, anti-inflammatory. You can use steroids, and in fact, if you look at the published data on Achilles tendinopathy, steroids is actually quite good. Steroids actually got pretty good evidence base for it, but we never use it because we all know that it's likely to end up with a rupture. Obliteration of near vessels. Interestingly, polydocanol is an agent that's used for varicose vein injections, and you can use it for hemorrhoids. In fact, if you look at what's published again, the best evidence base for percutaneous treatments for Achilles tendinopathy is polydocanol. The trouble is, the guy who wrote that, Alfredson and Olberg, I'm sure a lot of you will know, he doesn't do it anymore. If there was one good treatment, there'd only be one treatment. And high volume injection, which I know is quite popular in physio, because the first papers that were published in physio journals, and I have to say, I've done a lot of them, and I really like it. I think it's a very few times you inject a patient, you see them again in a few weeks' time to do the other side, and they've had a really good response. I mean, it's a good treatment, there's no doubt, but it is risky. But thank you very much.
My name is Sam Church. I'm a consultant knee surgeon at Fortius. I specialise in all aspects of knee surgery, including arthroplasty and revision arthroplasty, soft tissue knee surgery, ligament reconstruction, revision ligament reconstruction, and multi-ligament reconstruction. One of my specialist interests is anterior knee pain in the athlete and overuse syndromes of the knee. Welcome everyone. Thank you for coming. As Jay said, I'm Sam Church. I'm one of the knee surgeons at Fortius. I'm going to start quite dramatically by saying I do believe there is an epidemic out there, which is an epidemic of anterior knee pain amongst urban athletes who use running or cycling to maintain their fitness in their concrete jungle. And it really is common. It affects 1 in 5 active females, 1 in 8 active males. It affects 40% of military recruits during basic training. It's got an incidence of 2.5 million runners per annum in the USA. That's the number of new cases per year in the USA, and it is therefore undoubtedly the commonest cause of all knee pain. And yet, 5 years after completion of a rehab program, 80% of patients have persistent pain and 74% have a reduced activity level. So why is that? Well, the reason is that the medical community, and I mean medical, not physio community, the medical community does not want to admit that this condition exists. It doesn't know what causes it, it doesn't know how to treat it, and it hasn't even got a name for it. So why don't we start by trying to give it a name? Now, it's not patellofemoral pain syndrome because it doesn't originate from the patellofemoral joint. It's not quite ITB syndrome. ITB syndrome is a subset of this condition, but it is not the whole thing by any means. It's not runner's knee. Runner's knee usually refers to ITB syndrome, but I don't like that term because actually you can get it, or athletes across the whole spectrum can get this condition. It's not idiopathic anterior knee pain because it's not idiopathic, and it's certainly not chondromalacia patellae. So, as the title of my lecture may have suggested, what I like to use is the term lateral patellar overload syndrome. I think it's the most descriptive term, the most accurate term, and it's not open to so much misinterpretation as some of the other terms. So now that we've got a name for it, what causes it? Well, you guys know all this. We don't, but you do. It's poor biomechanics. The underlying problem is one of a weak gluteus medius. If you chuck in a bit of forefoot pronation with that, you get internal rotation of the hip during the stance phase of running. And then, when you have to initiate knee extension during the swing phase, it's done by TFL, by tensor fasciae lateralis and vastus lateralis, which are pointing forward rather than by VMO. And you get a vicious cycle of ITB dominance and glute weakness. And when you have this, repetitive knee flexion and extension leads to ITB bursitis or friction syndrome, which is well known but actually less common, or its very common and less well known cousin, which is superior lateral fat pad impingement. Who gets which one? Well, to understand that, you've got to know your ITB anatomy. If you put in ITB to Google Images, it will show this beautiful picture of this sort of belt-like thing running from the iliac crest down onto Gerdy's tubercle. But only about 15% of the ITB inserts into Gerdy's tubercle. The rest inserts all the way back as far down there as the fibular head, and it also forms basically the lateral retinaculum. It is the lateral retinaculum, and that is where the vast majority of its insertion goes. And so if you are predominantly varus and you're thrusting into varus as you run, you're going to put tension on the ITB portion that inserts into Gerdy's tubercle, and you're going to get ITB syndrome. But if you're predominantly valgus and you've already got a tight lateral retinaculum and you tighten up the ITB some more, then you're going to cause patellar tilt and you're going to pinch on the fat pad and you're going to get superior lateral fat pad impingement. That is a gross generalization. I've seen valgus knees with ITB and varus knees with fat pad impingement, but in general, if you look at most ITB syndromes, true ITB with nothing else, they're going to have varus knees. And more often than not, actually, patients have both, because it is one syndrome that just presents in two different ways. So how do we make the diagnosis? Well, as always, we start with the history. The history is classically lateral or anterolateral pain during or after running. ITB syndrome often comes on very quickly after a very predictable distance. So sort of 8K into a run, bang, it comes on rapidly in a matter of strides, and it can bring you to a halt. Fat pad impingement is slightly different. It will usually come on by the time you reach the end of your street, but it's milder, it grows much more slowly, and people are often able to complete their run, but they're punished afterwards for 24 hours or so. The symptoms will classically start with a change of exercise pattern. You're training for a big race, a change of footwear, a return from injury. That's the really classic one, when someone's been off with an ankle sprain for 2 or 3 months and they go straight back into their standard running pattern. Or a single significant event, which obviously we all know is the marathon, but actually probably more commonly is a descent from a high hill climb will often start it off. The symptoms will then become more frequent, and they'll progress onto the stage where the patients will even start to feel it during normal activities of daily living, such as walking downstairs, if they continue to run. Examination, I get the patient to stand up. I look at their coronal alignment. Are they varus? Are they valgus? For the reason that we spoke about before. I get them to do a single leg squat. This is something that you guys have always done, but no doctor includes as part of their standard examination. And you can see the pelvis drop. You can see the knee drop into valgus. I look at their feet, obviously, and then I look for tenderness. Are they tender in the fat pad? Are they tender over the ITB bursa? Fat pad tenderness in particular is quite hard to find, but if you dig your thumb in there and then you get them to extend the knee and keep your thumb there, you can find it very easily, and they'll say, that is the area of pain that I get. And you'll often find crepitus with it. That crepitus is not irregularity of the articular surface on the back of the patella, as most people think it is. It's fibrosis in the fat pad that causes the crepitus as a result of chronic inflammation. I'll look at their patellar tracking. If that is bad, if that's way off, they've got a big J sign, if they've got lots of lateral glide, lots of patellar tilt, it may be that you need to consider a tibial tubercle transfer in some of these patients, but that's rare. Look at how tight their hamstrings are, which you guys know all about. Then I'll do a modified Overuse test, and we've modified Overuse tests in my clinic so many times now that I can't really remember what the original one was, but it's something similar to what this girl's doing here, except that I would have the contralateral leg flexed up much more to fix the pelvis much more, and I would have my hip against the patient's sacrum to stop them tilting backwards as you bring the hip up and out into abduction and extension. Then I'd come down into adduction, and we gauge how tight the ITB is by where it sort of flops to, and anything horizontal or above is tight. And then the way we've further modified it is once you've tightened it, once you've got it to its point of maximum stretch, if you then flex and extend in that position, you can perfectly recreate their symptoms. Even in the patient who said, oh, I haven't had symptoms for weeks, you can bring that back on. And then modified Thomas's test is also great visually, and we'll come back to that in a tick. Investigations. There's only one investigation really that's helpful here, and that is an MRI scan. But crucially, you've got to do it when the patient is symptomatic. So they've got to be symptomatic. Get them to run up and down the stairs before they walk into the scanner. If you do that, you'll convert this, which is some nice sort of mild inflammation, as Jay showed before, between the lateral epicondyle and the ITB. This same patient, after running up and down the stairs, looked like that. So there's the proximal edema that Jay talked about. And then this lady just happened to be a professional marathon runner, and she let me scan her knee the day after doing the Loch Ness Marathon, and we got a picture very similar, but I think more dramatic than the one that Jay showed earlier on, where the fluid is actually tracking all the way down into the lower leg. Fat pad impingement is more predictable on an MRI scan. You can usually pick it up if it's there. This is it on the axial view. You can see it's that area there. You can see it on the sagittal view there. And you can see it if you get a good coronal slice straight through the fat pad in the right place. You can see it beautifully here, where this side of the fat pad, the lateral side, is inflamed and the medial side is not. And the reason I showed these films is that these are the patient I saw a couple of months ago for a second opinion who'd had this MRI done elsewhere, and it was reported as normal. The vast majority of radiologists around this country will report this as normal. It was Jay and his clan who started to recognise this as a separate entity. But more often than not, as I said earlier, the patients have a combination of both. It's very rare to get one in complete isolation. So here's a typical patient where you've got fat pad impingement here on the sagittal view. You've got ITB syndrome on the coronal view, and then the axial view shows it quite nicely on both. So how do we treat these patients? Well, as surgeons, if someone comes in with knee pain, we target the knee, and you know, a lot of physios do the same thing. They do knee-orientated physiotherapy, ITB stretches, VMO strengthening. And then cortisone is a really interesting one, because cortisone is never going to change the underlying biomechanical problem, but it can be useful. I accept the fact it can be useful. It can persuade a patient who's had umpteen courses of physiotherapy to maybe give it one more go if you can get rid of their symptoms for a short time. It can be useful in the person now who gets ITB syndrome and is desperate to run the marathon but intends never to run ever again. It might get them through that. But it does not change the underlying biomechanical problem, and it does not treat them. The correct treatment, however, is to target the hip, because that's where the problem is. If you can strengthen gluteus medius, if you can keep the pelvis nice and steady while the patient's running, then you can present the VMO facing forward as they're running, and they won't get this problem. And there was a great paper as long ago as 2005 in the American Journal of Sports Medicine, where they divided patients up into patients who had hip physio, knee physio, and a combination of both. And they said that physiotherapy that was directed solely at strengthening gluteus medius was 93% successful in treating activity-related anterior knee pain. If this one parameter didn't change, the success rate was 0%. So you can get the VMO as strong as you want, but if it's facing backwards when they're running, you're not going to use it anyway. But what happens when physio doesn't work? And I know you're all brilliant, but I bet you every now and again you've had a patient that you can't treat with these sort of overuse syndromes. It's very common. I mean, by the time I see them, by definition, physio hasn't worked. They might have had 2 or 3 courses. They might have shopped all around London, trying different people, and they've still got it. As surgeons, we have 3 main tools. We've got you guys, physiotherapy. We've got injection therapy, i.e. J, and then we've got surgery. And so if they've had a cortisone injection and they've had physio, we all tend to think of surgery. And what surgery can we do? Well, if they've got ITB syndrome, you can do an ITB release, which I'll talk a little bit about later. But again, that doesn't change the underlying problem. You can do, if they've got fat pad impingement, you can do an arthroscopic fat pad debridement. I don't think I've ever seen that work. I mean, if it's really bulky, you can go in and shave it out a bit, but then there's the number of problems you see after arthroscopic fat pad work is probably more than the problem you see in the first place. But the alternative, this is where my Botox bit comes in. If we can switch off the ITB completely, if we can switch off TFL to give gluteus medius a chance to function, a chance to get back up and to compete with it, then maybe we can solve the problem. So I inject a particular variety of Botox called Dysport into the belly of tensor fascia lata under ultrasound guidance. This works for 12 weeks essentially. So it gives a 12-week window of TFL paralysis during which the physiotherapist can work on recruiting and strengthening their gluteus medius and secondarily their VMO. And I've had quite a few physios have this themselves, and they say that the minute they have it, well, not quite the minute, but within a few hours, they can feel that they are using their glute med and no longer using their TFL once they've had it done. It's a very dramatic effect. So when we first started doing this 5 or 6 years ago, we set up a pilot study looking at 25 patients just to make sure that this was a viable thing to do. And to cut a long story short, we measured ITB length using a fluid goniometer. It was a validated method, and we confirmed that by paralysing the TFL, the ITB was lengthening, and we were therefore defunctioning it. And we also confirmed that the patient's Kajala score, which is a patellofemoral function score, increased significantly. But what was really happening, what was really interesting is what happened next, i.e. once the Botox wore off. And 19 of the 25 knees remained satisfied and required no further treatment, i.e. glute med got strong again, it could compete with TFL, and their biomechanics were once again in line. 6 of them, the ITB came back to dominant again. They have a further injection, of which 3 were subsequently satisfied. And then the remaining 3 I gave up and I lengthened their ITB, 2 of which improved, so we had a 96% satisfaction, and all of these patients had failed conventional treatment. In other words, this was 96% where conventional was 0%. How do I do my ITB lengthening? So when the Botox does work, but it keeps on recurring, I need to lengthen the ITB permanently. I do it through a small incision on the lateral aspect of the knee. And after this, I'm just going to show you a series of simple diagrams to try and explain what I do. This is obviously the lateral femoral condyle here. This is the lateral epicondyle, and this represents the ITB band coming over the top. And most people, a traditional operation, one which I did a lot in Australia, there's an awful lot of ITB syndrome in Australia, is an ITB release, which is just where you cut down through the posterior 2/3 of the fibres at the level of the lateral epicondyle. And so it springs apart, it releases the bursa. The bursa is no longer under pressure, and so the patient's symptoms should resolve. But the problem is, these fibres here, anterior third, are all still intact, so the ITB remains the same length. What I do is I've added in another incision more proximal to that through the anterior 2/3, so actually every single fibre in the ITB is being divided, and that way it can actually properly lengthen it. It's a well-known plastic surgery technique called a Z lengthening. So you get this effect and you get that, and that adds genuine length. It effectively defunctions the ITB, which then means that the patient uses their glute med. So my current algorithm for these patients is to MRI them, determine whether they're fat pad, ITB, or both. They always have a course of good physio, and you ask them, if they've seen lots of different physios, you ask them, what have you been doing? Have you been, you know, what is glute med? And they go, what? And so you make sure they have a good course of physiotherapy, and I do generally inject every single one of them with cortisone because I have to, because I'm not allowed to use Botox off license, which is how I'm using it, unless I have exhausted conventional treatment, and conventional treatment includes cortisone. So I have to do that, and it gives the patient a brief window of pain relief as well. I'll then do Botox, which I will repeat up to 3 times, and the patients will often get better and better and better after each one, but if they're still symptomatic after 3, I'll go on and do the ITB lengthening. So we've now injected over 200 patients. 38 of them have gone on to have an ITB lengthening, so about 20%. And we're formally writing up our data with Imperial College at the moment. So I can't give you exact facts and figures, but our research analysts have said that basically about 80% of patients feel that they have been successfully treated. Now that still means 1 in 5 is not, but that's an awful lot better than the 4 out of 5 using conventional treatment. In summary, lateral patellar overload syndrome is a very common cause of anterior knee pain in runners. The underlying cause is a biomechanical imbalance at the hip. You guys should primarily address recruitment and strengthening of gluteus medius. Cortisone injections can be useful, but are short-lived. And if physio fails, defunctioning the ITB with an ultrasound-guided injection of Botox into TFL or surgical lengthening of the ITB results in significantly better long-term relief than conventional alternatives. Thank you very much.
Hi, my name is John Rees. I work as a consultant in rheumatology and sport and exercise medicine. I've been a consultant for about 12 years. So I'm interested in all general aspects of rheumatology and also all general aspects of sport and exercise medicine. In particular, I've got a big expertise working in rehabilitation, having worked at the Defence Medical Rehabilitation Centre, Headley Court, for 9 years as a consultant there. And also I've worked a lot in elite sport at all levels, Olympics, Paralympics, professional football, rugby, etc. But I'm probably most known for my work on tendons, which is what I did my medical doctorate on, and the work I've published in that area. I was going to, more sort of general broad brush, to say what causes injury, why do injuries happen, and if we know why they happen, can we think about how we could prevent them. I'll talk a little bit about exercise-induced pain and how thinking has changed in that, and talk a bit about barefoot running as well. Is it something that I should be doing? Is it something that my patients should be doing? Is this something we should be advocating, or is that asking for trouble? Speaking as someone who's provided medical cover for the marathon, that's probably perhaps the big MSK injury is the biggest bulk of your work, but cardiac events, they might be uncommon, but they do occur, and tragically that can be severe. Circulatory collapse, I've had to deal with that about halfway out, and that's quite frightening if you've got someone who's got no pulse in front of you. And then perhaps later on, hypo and hypothermia, exercise-induced collapse, hyponatremia, fitting, etc., gastrointestinal, mesenteric issues, etc. So there's a whole load of medical issues associated with marathon running. Okay, that's my only slide, or only 2 slides about the medical side of it. The rest is more on the sort of injury side. But I'm trying to think of a definition for why we get injured. And the simplest one I can think of is when injury occurs when load exceeds tissue resilience. And that can be acute, i.e. trauma. That's essentially where load's exceeding the resilience of the tissue to absorb it, or chronic, or anything else in between. Traditional medical thinking of, well, rest, drugs, if that doesn't work, you inject, if that doesn't work, you operate. It's kind of not appropriate for many running injuries, especially, a lot of sports injuries in fact, but especially running. And generally speaking, if you look hard enough, running injuries have an identifiable cause, okay? In terms of working out what that is, history is the most sensitive. Examination can help. The diagnostics can help as well. They can certainly help, in particular, I think, on severity. But really, the diagnostics are there to confirm your findings. What I do, I spend a lot of time talking to my patient about, why has injury happened in the first place. And if all the patients are sensible and train correctly, then they'll train, and that degrades the tissue a bit. It puts strain on the tissue. But if you rest and recover, you have super recovery, super normal recovery, etc. Over a period of time, you get stronger, and you can all have your own definitions of success. That might be Super Saturday, Olympics, what have you. But then the patients that present to me, and I guess to many of you, they train a bit more, or they're a bit older, or they train too hard, or they're unaccustomed. They've had a layoff, and the recovery isn't as good as it was. And then over a period of time, this may be completely asymptomatic, and then eventually your stress response, your typical stress syndrome, may complete. And it happens, and it's out there. But to me, it's all about force and the distribution of that force. What we have here is we have a 3/4 of a ton crushed car, and it's supported on eggshells. That's it. Okay. So if you load in a nice uniform, in a beautiful way, and you spread that load, something as humble as the eggshell can be extremely strong. And in fact, not only can it support one car, it can support 2 cars. The principle is the same, that if force is balanced throughout the body in an even way, and you're not concentrating force on one particular area, for example, the lateral knee, then it's incredible what structures can, that they're beautifully designed, can withstand. And I know that Jay's already gone into this a little bit, but essentially that distribution of force is dependent upon your intrinsic and your extrinsic factors. Intrinsic factors, generally things you can't do much about. Genetics, well, not yet. Age, certainly not. Biomechanics, perhaps we can do a bit there. Medical history, you can't change the past. Bone health, well, maybe we can intervene there. And as a physician, I'm a rheumatologist as well, and the bone health of athletes, people having stress fractures, comes a lot into my work, and sort of optimization of bone health. That is something that we can work on. Extrinsic factors, load, the frequency of load. So it's not just how much load is, but have people gone from a small load gradually up to a big load? Genetics. Genetics is pretty important. For example, with tendons, the work of Malcolm Collins has showed that there's certain people with certain genes with the Achilles tendon, and they are just predisposed, are less resilient to injury than others. And they may have an influence on your biomechanics. And this is not an exhaustive list, but it's just some examples of some of the things that we all see. But perhaps something that makes us good, hypermobility, can also be our vulnerability. And how often is it that you see people who are very hypermobile? And I see a huge number of hypermobile people in my clinic. Yes, there are certain sports, ballet, gymnastics, hurdling, that they would be very good at doing, but that can give people their own individual inherent weakness. So you could say, well, what's the physician's role in all of this? And I think where a physician can be useful is it helps to confirm the diagnosis. I think also it's important to consider the patient as a whole. For example, what is the bone healing? What is there anything we can do to that? Is there anything else that we can optimize to help that patient recover? Imaging, in particular, can help us confirm severity and help give us a prognosis. It can help guide us how to guide that person back to health. I do a lot of musculoskeletal ultrasound in my practice. I think patients they love ultrasound because they get a bit of feedback at the time with the right radiologist, and that's very helpful. Perhaps one of the other things a physician can do is do something to get the patient out of pain. So you guys can actually do something with them, because that's what they come with. They come with pain. They don't come with, is it ITB or not? They come with pain and they can't run. Something else, psychological support, and appropriate rehab plan. That's, if you like, that's the role of a physician. What would a principle of rehab plan? Well, treat and remove pain. If you don't do that, then that's going to be quite difficult, and that could facilitate the re-establishment of a normal movement pattern. One thing I learned very much was you've got to try and avoid the physical deconditioning. If you can't run, there's always something you can do. But how often do you see someone that come in and they've piled on the pounds, and that just makes things so much more difficult. They feel unfit. But if you can get them doing something, there's endorphin release. They feel less stressed, and although it might not be what they want to do. Address the cause, general conditioning, etc., etc. But the psychology of injury, something that perhaps we haven't discussed until now, is it's so important. With injury comes a loss of confidence, and that's not just, if I'm injured, can't do the sport I want, that makes me feel bad. But if it's what you do, if you're an athlete, if your whole being is wound up in that, then there can be a tremendous loss of confidence, a feeling of insecurity. And how you progress through the denial, anger, depression, acceptance phase can be critical as to how successful you are at your outcome. So the traditional thinking was that your compartment is too small, and as you exercise, the muscle expands and the pressure builds up, and that leads to pain, which you cannot run through. It is often bilateral, and it has a predictable onset. The pain is described as crescendo. It builds up and up and up and up until it forces you to stop. There may be a tingling or a paresthesia in the feet. There may be foot slapping. The gait changes, and a tightness, a burning like something about to burst. And it fades. It fades away after 30 to 60 minutes, and then you can carry on running again. Okay. And you may, the only sort of signs really, particularly immediately post or during exercise, you can see these muscle hernias, which does suggest that there's increased muscle pressure in here, tibialis anterior, the anterior compartment. How do you select the right patients for surgery? Well, apart from your history, examination, you would do an investigation. And there isn't space for radiology particularly, but you would do a pressure catheter. And if the reading was high, then that would be an indication for surgery in the right patients. So it's a pretty straightforward procedure to put a catheter in here. You're well away from the vascular bundle, and then ideally you want to get the patient doing as physiological an exercise as possible, i.e. put them on a treadmill, get them to run. You can do the same for posterior compartment. It's helpful to have ultrasound to ensure you don't go into the neurovascular bundle. Essentially, the principle is the same. And then if you have a positive study, you'll get right or left very high, that sort of resting, and crescendo increasing pressures in your compartment. But despite standardising our surgeons, standardising the rehab trying to get the best possible patients together, the most accurately tight defined homogeneous group, and I think any surgeon will tell you one of the secrets of good surgery is good patient selection. Often the post-op results were quite poor, despite high intermuscular pressures. Why is that? I mean, there are a few reasons. It may be they just scar up again. And so the operation perhaps it's technically successful, but for some other reason it just scars up and it doesn't effectively release the fascia. So given that surgery wasn't that successful, was there an alternative way of managing these patients? And if you start to look at the diagnosis, you realise that it's perhaps not as concrete as you might think. Certainly, if you overload tib band, that's going to fatigue more quickly than gastrocnemius. That's well known. And we saw a high incidence of excessive heel striking in these patients. So fatigue and overloading, that can cause pain. Well, we know that. Barefoot running is not new. Well, some of us remember Zola Budd, some are older ones. The famous race with Mary Decker. What did change in the 70s, we had the sort of inception of the modern running shoes with your midfoot support, your anti-pronation, your big heel, and go faster stripes, whatever really. But effectively what this does is this turns us into a nation or a world where it promotes excessive heel strike and then forefoot off. Apparently, they can correct for high arch, flat foot as well, but obviously has been criticised. And is there another way? But does it actually work? And if the arguments are from Lieberman and McDougall, so we've been running for hundreds of thousands of years. The modern shoe's only been around a while. There's an epidemic of running injuries. Some people would have you believe that that's perhaps the cause. But certainly there might not necessarily be much evidence that the modern shoe reduces injury. Lieberman's work, if you look at pressure, essentially it doesn't really show a reduced force, but it shows a slower rate of force loading and without a peak from your heel strike, and so it's smoother, and the argument is that this will lead to less pressure, less force leads to less injury. Barefoot running promotes forefoot or midfoot impact, shorter stride length, higher cadence, that's the other thing that was in our program, and a more forward leaning centre of gravity. So reduce forces, certainly yes to a degree. Reduce injury rates, certainly it may promote a better style of running, and I think excessive heel strike is bad. I think that's a reasonable tenet to take from it. But perhaps you've got responders and non-responders. The responders don't come to your clinics because they don't need to, and we see the non-responders. So my view on barefoot running is it promotes a more economical gait. That's good if we transition slowly. It'll suit some more than others, but it's a skill. It requires a careful transition. But I think you can think of it, and it does make sense when we think of forces, distribution of forces in terms of injury and injury occurrence.